Hello, this webinar will be about the physiotherapeutic scoliosis-specific exercises, PSSE-Schroth method, the latest advancement in scoliosis treatment. The educational program for the webinar will start with an introduction of kyphosis and scoliosis evaluation, followed by a presentation of the PSSE schools and the scientific evidence and treatment indications. Later on, we'll take a look on our newly developed PSSE-Schroth classification and 3D principles of correction, and we'll finish with some of our treatment results. When you look the spine from the back view, normally the spine should be straight, but when you look the spine from the side view, it is not straight. We have normal curvature showing the sagittal profile. So there is a cervical lordosis, thoracic kyphosis, and lumbar lordosis. However, for these curves, there are some normal ranges. And according to the Scoliosis Research Society, the normal range for kyphosis is between 20 and 50 degrees or 25 to 40 degrees, measured by T4 as upper end vertebra and T12 as lower end vertebra. And lordosis is between 30 and 70 degrees, measured from L1 to S1. The first thing that we need to clarify when we need to differentiate between functional and Sherman kyphosis is to have a proper clinical evaluation. So there are some clinical and radiological criteria that we have to take a look to decide if this kyphosis is functional or Sherman kyphosis. Please always remember that when you evaluate a patient, you will need to start with a clinical evaluation. This is the normal way to start, and of course to help your clinical reasoning, so that you take a look on the patient in front of you and then you go to double check on the x-ray to confirm your clinical diagnosis. So in functional kyphosis, we have quite flexible spine and no angular kyphotic hump on the Adams test when you look the patient from the side view. But in Sherman kyphosis, we have a spine rigidity and an angular kyphotic hump, like what you see in the right photo. The radiological criteria to differentiate between functional and Sherman kyphosis are the vertebral wedging on the ventral part of the vertebral body, and you need to have 3 wedged vertebrae with angle more than 5 degrees. So when you measure the angle between the upper and the lower platform of these consecutive vertebrae, you need to find an angle more than 5 degrees. There is another criteria on the X-ray, which is the increased anterior posterior diameter, and sometimes you can also see some spare nodes. There are some types that they are having no criteria, neither clinical nor radiological, and these are functional kyphosis. So for them, the treatment option is to do only exercises, and these could be enough for these patients. There are also some other cases that they have all the criteria, both clinical and radiological. So these are typical Sherman kyphosis patients, and for those you need to have brace treatment whether they are still in growth. But at the same time, there are some patients fulfilling some of the criteria, but not all of them. For example, you might have a patient that they have a spine rigidity, but no angular hump. Or you might have a patient with 1 or 2 consecutive wedged vertebrae, but not 3. These cases are called atypical Sherman kyphosis, and for them, it's difficult to decide, so they are on the borderline to be braced or not. This is a typical case of thoracic Sherman kyphosis. So we have all the radiological and all the clinical criteria: spine rigidity, angular hump, and 3 consecutive wedged vertebrae. Now, let's take a look on adolescent idiopathic scoliosis. The word scoliosis is actually coming from the ancient Greek word skolios, which means crooked crooked or curved. And although many works they have done from the past to identify the cause of idiopathic scoliosis, it has not been found yet. So this is why it is still called idiopathic. The definition of scoliosis, according to Scoliosis Research Society, is mostly radiological, and it is defined as a lateral deviation of the spine with comb angle more than 10 degrees with rotation of unknown reason. The SOSORT, the Society on Scoliosis, Orthopedic and Rehabilitation Treatment, which is working for the non-operative treatment of scoliosis, gives a definition which is a little bit more complete and not only based in radiological terms. So according to the SOSORT, idiopathic scoliosis can be defined as a complex three-dimensional deformity of the spine and the trunk. So it's not only the spine, it's also the trunk, which appears in apparently healthy children. So people suffering from scoliosis are not ill. We actually call them patients, but they are not patients, they are healthy people, and can progress in relation to multiple factors. We know scoliosis is multifactorial disease. During any rapid period of growth or even later in life, we know that we also have the de novo scoliosis, which did not exist in adolescence, but it was developed in adult life, coming after of disc degeneration most of the times. The first thing you need to evaluate when you have a scoliosis patient is to define whether this scoliosis is structural or functional. So again, I have to repeat that the first thing is to look at the patient clinically, and then you go to confirm your clinical diagnosis in the X-ray. So the criteria to decide whether this is structural or not is to do the forward bending test, Adams test. And you need on that to find the lateral deviation of the spinous processes and a hump on one side of the trunk. So like in this case, when you can see a right thoracic scoliosis with a right thoracic hump. So this is a clinical confirmation of a structural scoliosis. And in standing position, of course, you can notice some trunk asymmetry and lateral deviation of the spine, or pelvic imbalance, or the scapula imbalance. Or if you take a look on the triangles between the trunk and the arms, you can probably see that there is different on one side to the other. And of course, this is quite big scoliosis. The most typical case of structural scoliosis is idiopathic, 75 to 80%, but we can also have neuromuscular, congenital, syndromic, or from neurofibromatosis. For idiopathic scoliosis, we don't know the exact cause, but what we definitely know is the pathomechanism of progression, so how the scoliosis can go into progression. So we have a triggering event for an unknown reason, and we have a development of a spinal curvature, which is always in 3 dimensions. And we have an asymmetrical loading on the spine, and the asymmetrical loading on the spine causes an asymmetric growth of the vertebra. So deformity of the vertebra wedging, which is definitely clear on the X-ray, and the bigger the scoliosis, the more obvious what you can see on the X-ray. So you can see that the convex side of the vertebral body are growing faster than the concave sides, and also the discs and also the ribs are closer on one side. So what is in the concavity is growing faster and is collapsing. So we have asymmetrical loading, which causes asymmetrical growth, vertebra wedging, more scoliosis, more asymmetrical loading, more asymmetric growth, more vertebra wedging, more scoliosis. So we have a vicious cycle that is developed to make scoliosis to progress. And this is the mechanical explanation of scoliosis progression. However, we know that etiopathogenesis and progression is also related to many other factors. So what we can do to treat scoliosis is that we actually need to break this vicious cycle, and we need to reduce the asymmetrical loading of the spine. This is what we do with non-operative treatment. So to make it even more clear for you, we need to have the patient avoiding the scoliotic position during the day. Because if the patient goes to the scoliotic position, this means that the asymmetrical loading is there and causing asymmetric growth, vertebra wedging, and scoliosis progression. And it's clear that the most important period of time and the highest risk of progression is definitely at the peak of growth, when you have rapid growth and asymmetric growth at the same time, which means that the risk for the rapid progression is very significant. So when we have mild scoliosis, usually we call it when it is less than 25 degrees. We can treat this scoliosis only with exercises. But when the curve is more than 25 degrees, we need a stable correction during the day, and this is the role of the brace, to keep the spine in correction for many hours during the day. Therefore, for mild scoliosis, maybe scoliosis-specific exercises can be enough to treat the scoliosis, but when scoliosis is getting bigger and the patient is still in growth, we need a combination of brace and exercises. We know that scoliosis is a 3D deformity of the spine and the trunk, and it comes from the mechanical phenomenon of torsion. As you can see here, the spine is deviated and rotated at the same time, and this is what you can see on the X-ray or on the clinical image of the patient. Here we have a description that it comes from many years ago about the 3D vertebra deformity. So when you take a look, you can see that the concave side of the vertebra is shorter than the convex. So we have wedging on the frontal plane. There is also different orientation of the platforms of the vertebra. So this is deformity on the transversal plane. And we also have ventral faster growth of the vertebra and disc. So we have these so-called relative anterior spinal overgrowth, which was found to be a mechanism that is accompanying the 3D torsion of the spine. So in these very nice images, you can see the 3D deformity of the vertebra, and here we also have a representation of the spine from the top view, when you can see better the horizontal plane, which describes even better the 3D torsional phenomenon, which is related to scoliosis progression. Our role as specialized physiotherapists is not only to treat the patient with exercises, but I believe our role is really important for the clinical evaluation of the patient and the follow-up. So we are those that we can make all these measurements to be able to identify at any stage of the treatment if we're going well or not. And this is really important because we are those that we spend more time with our patients. We have the clinical tools to make these measurements so that we can inform the whole therapeutic team about the quality of our treatment. One of them is the scoliometer, which is a very easy tool to be used. You can measure your patient many times. We use also some anthropometrics data, body symmetry indexes like the trace and the POCI. We can use a spirometry for the patients that have severe scoliosis, or we can deliver to them to fill in the questionnaires that are designed for evaluating how the patient feels about the treatment result, and clinical photos, of course. And we need to have a proper documentation, a data recording to evaluate the treatment process, and also to have a self-evaluation, and of course to provide future evidence for proving the effectiveness of the treatment that we follow. And my advice here is that you have to be very strict with yourselves, because my perception is that a physiotherapist is not only there for the success. So don't try to think that you are a part of the success when something is going well, and at the same time saying that when you have a poor treatment result, that it was not your fault. You have always to analyze what went wrong for this patient. Why did they not do the exercises? Maybe you need to change your strategy. Maybe you need to find a way to motivate them even more to do the exercises. So please try to be strict with yourselves and consider you as a part of the fail when something is not going well, not only as a part of the success when you have a good treatment result. And I think that this is the way how you can improve, and you can find new ways, new strategies to approach your patient. Because at the end of the day, what makes a good therapist is a finally good treatment result and a satisfied patient, not only a satisfied therapist. So just to give you a few more information about these clinical tools that we can use, one of the most important is the scoliometer, and I think that every specialized physiotherapist in scoliosis field, they need to have a scoliometer in their clinic. So we can make the forward bending test in standing or sitting position. We usually prefer sitting when we suspect that there might be a leg length discrepancy, so that the pelvis is imbalanced, and you need to put the pelvis in balance with no tilt in sitting position, and then you ask the patient to bend forward. So to measure by the scoliometer, you need to put this curve of the tool just above the spinous processes, and going down to the spine, you keep the highest value of measurement. And we know that angle of trunk rotation is an important prognostic factor, and the maximum rotation is at the apical region, and it is recommended to make a regular re-evaluation. I would say at least once a month you need to measure your patients, or maybe even once every 2 weeks to have a proper follow-up. Then you can use the anthropometric data. For example, you can measure the standing height of the patient to estimate velocity of growth. The sitting height is another good way to use. So you must have the same stool or chair and the same meter, and what you measure is the trunk height, so the velocity of growth in the trunk, and this is important, especially in brace patients. Another measurement you can do is the standing height with a brace. So you can measure the patient without the brace and immediately after when they put the brace. And if the difference in the standing height is good, so more than 2 centimeters or 3 or even more, it means that the brace is correcting very well the scoliosis, because the patient seems to be taller in the brace. The arm span is another measurement, or the body weight and the thorax perimeter, or the pelvic perimeter measurements. Very important, especially again in brace patients, that you need to evaluate the fitting of the brace on them. The thoracic expansion can be measured in 3 different places, so the axilla level, xiphoid apophysis, and the waist level. So you can ask the patient to go from a deep exhalation, from a long exhalation, sorry, to a deep inhalation, and you can measure the expansion in centimeters. And of course, sometimes you can also do a manual measurement of the leg length, especially when you suspect that there is a true leg length discrepancy. These are some of the clinical scales that you can use to evaluate the body symmetry, like the trunk appearance clinical evaluation scale, when you can see the asymmetry on the shoulders, where you get a score from 0 to 3, on the pelvis from 0 to 2, from the 0 to 4, and on scapula and thorax from 0 to 2. So you have a final score from 0 to 11. You can also use the POCI index, posterior trunk symmetry index, or there is also here the anterior trunk symmetry index, the ATSI. So you take photos of the patient and you measure all these distances, and after an algorithm, you have a result of the body symmetry. Spirometry is a tool to evaluate the breathing function of the patient. We expect that in severe thoracic scoliosis, there is an impairment of the breathing function most of the times. So the most important values are the vital capacity, the forced vital capacity, and the forced expiratory volume in the first second. You can do this evaluation every 6 or 12 months, so that you can have an estimation of breathing function of the patient. All these measurements are made by the physiotherapist, so we can have our own criteria to follow up the patient. However, what is most important at the end of the day is how the patient feel about their treatment process and if they are satisfied or not. So for this reason, we have many questionnaires that are developed for the patients with scoliosis. One of them is the trunk appearance perception scale, which is about self-image, and the patient can tick on the questionnaire how they imagine themselves to be when they look them from the back or from the front or in the forward bending position. So you can give them at the start of the treatment and then after some months to have a reevaluation. One of the mostly used questionnaires is the SRS-22 questionnaire, which is related to quality of life. We have 5 subcategories: pain, mental health, self-image, function, and treatment satisfaction. So every question gets a score, and we have a total score from 20 to 100. There is another questionnaire, the BRACE questionnaire, that is developed for patients with scoliosis that wear a brace. And there are 34 questions. We usually give these at least 3 months after the first fitting, so that we can allow some time for the patient to get used to the brace before we ask them to fill in the questionnaire about their feelings when they wear the brace. And we have 8 different sections: general health, physical activity, emotional function, clinical appearance, vitality, school activities, pain, and social function. And again, each question goes from 1 to 5, and we have a total score in percentage. Another important way to evaluate your patient is to take clinical photos of them. So you need to standardize the position of the camera if possible, and if you can use the scoliogram, so this is on the background, it is useful because you can identify even very minor differences from one photo to the other. You need proper clothing, so usually for boys, you take them naked in the upper trunk, and for girls, you ask them to wear a sport bra. Of course, you have to take the photos before the exercises and in neutral position. So please take care, because the patients, when you ask them to make photos with them, they know that this will be a part of their evaluation. So most of the times they try to correct themselves in some way, and you need to ask them, please stay in neutral position, not correct yourselves. And of course, when you take photos to have a clinical comparison, the photos should be taken before starting the exercises, because after the exercise, you might have a better result in the comparison, but this would not be true because this is just the immediate effect after the exercises. So you need to take care on that. And also, please be aware about the patient that they wear a brace. My recommendation is that when you ask your patients to have new photos and they are in brace treatment, you can tell them, please, the next time when you come to our clinic for taking photos, you must be at least 2 hours without the brace, so that you minimize the effect of the correction by the brace, so that you can be sure that the clinical comparison will be reliable and not affected by the correction of the brace. Now, let's take a look on the aims of conservative treatment with scoliosis-specific exercises. We need to have a 3D treatment of the deformity. So scoliosis is a 3-dimensional deformity, and we need to apply the corrections in all 3 dimensions. The main aim is always to halt progression. So please take care on that. Even if you treat a scoliosis of 15 degrees, just with scoliosis-specific exercises, or if you treat a mild scoliosis of 30 degrees with brace and exercises, or a more severe scoliosis, for example, 50 degrees, always the main aim during adolescence is to stop progression, because we know that the natural history of this scoliosis would most probably be to progress. So if you stop progression, you have achieve the minimum aim, that scoliosis is not getting worse. Of course, many times when you have proper treatment with a good brace, for example, and good program of exercises, with the patient being compliant with the treatment plan, then you can even expect to have a partial correction, but you cannot promise that a priori. Because it is related to many other parameters. So please take care how you represent these to your patients and the families to avoid misunderstandings. Of course, you need to improve clinical appearance and aesthetics. This is one of the most important reasons why a patient with scoliosis is seeking for treatment. You must train them for the activities of daily living. And especially in adults, you need to decrease the pain. Many times the adult population with scoliosis, they come to our clinic due to pain. You need to improve the breathing function, especially in severe thoracic scoliosis. And generally speaking, you need to improve their quality of life. This is a term that is used to describe scoliosis-specific exercises, is physiotherapeutic scoliosis-specific exercises, and this term was introduced approximately 10 years ago to differentiate between what is really specific and what is non-specific for scoliosis treatment. And according to the SOSOT, these methods should be curve pattern specific exercises and should have some common basic characteristics. So the 3D autocorrection, the patient education for the activities of daily living, and the stabilization of the corrected posture. And as you can see, there are many approaches coming from different countries. So we have the SEAS from Italy, Lyon from France, international Schroth Scoliosis treatment from Germany, and Schroth Best Practice as well. Barcelona Scoliosis Physical Therapy School Rigo Concept from Spain, Dobomed and Fitch from Poland, SideShift from United Kingdom, and the latest development for PSSE is coming from Greece, is our technique, the Physiotherapeutic Scoliosis Specific Exercises Schroth method, which will be described in more details later in this presentation. So at that time, I would like to give my respect to my mentors, my teachers. I consider myself to be very lucky that I had the chance to be educated by some of the masters in scoliosis treatment. And of course, I'm really thankful to all of them for giving me this education. Dr. Manuel Rigo from Barcelona Scoliosis Physical Therapy School Rigo Concept. This was the school that I used to teach for the last 5 years. Axel Hens from Schroth International Schroth Scoliosis Treatment from Asclepios Clinic in Bad Sobenheim in Germany. Dr. Hans Rudolf Weiss from Schroth Best Practice, Dr. Jean-Claude Demoroy from Lyon, and Michele Romano and Stefano Negrini from the SEAS. I'm really grateful that I had this education by them, and by developing my own ideas and combining techniques and ideas from these schools, these created the PSSE-Schroth method. So this is the latest advancement in scoliosis treatment with scoliosis-specific exercises. So our method is a program of physiotherapeutic scoliosis-specific exercises that works for scoliosis and kyphosis treatment. And we have a totally new curve type classification and many innovative ideas for 3D concept of correction. Of course, we have received some influences from many PSSE schools, as I was personally certified in 5 different schools so far. But the basis is the original Schroth method, and it was developed by adapting concepts and techniques from all these PSSE schools and trying to keep all their advantages and to improve all their limitations. So this was the purpose for developing this new technique. And on this slide, I would like to spend some time to explain some of the strengths and limitations of the other PSSE schools that I was already certified before creating my own school. I need to clarify at that point that by explaining the limitations of these schools, this does not mean that these schools are not good or are worse or anything. Of course, all of them, they are very good methods to treat scoliosis, with most of them having good scientific evidence behind them. So I would like to go one by one to explain that. Before that, I would also like to share with you my perception about, the diversity of methods and techniques in scoliosis treatment. I always believe that for any therapist, it is really good to follow many different schools so that they can be able to identify by themselves how these approaches can work, and then they can have their own criteria to compare. So you need to compare different treatment techniques to be able to understand better scoliosis treatment. And my recommendation for all of you is that if you have the chance to follow any of these schools or courses, it will be beneficial for you. And this was actually the way PSSE-Schroth method was finally introduced, coming from my experience, my education from many different schools, and of course, my new ideas to create this new method for scoliosis treatment. So let's take a look one by one in the schools, starting from the BSPTS-Rigo Concept. I think main strength of these schools, of this school, is the theoretical education, which is of high quality, simple clinical classification, and the accuracy of corrections during the exercises, trying to avoid incompensations. I think that for this school, there is an advantage in double and balanced curves compared to some other PSSE schools. And also there is an excellent work by Manuel Rigo for his radiological classification, which is also used for brace design. Some of the limitations of the school could be too long educational plan, which is 21 days to get a final certification. A little bit complicated application of exercises sometimes, and can be a little bit time consuming for education of patients and therapists. So you need more time with them. And nowadays, this could be a practical problem for many patients and families. Another limitation could be the less variety of exercises compared to other schools, especially in first levels. So level 1, until level 1 in Barcelona school, there are only 5 positions to treat your patients, and maybe this could not be enough in some cases. There is low potential for overcorrection because only one type of this school can get an overcorrection for the main curve. There is quite complicated educational plan and online basic courses given without an instructor. So these could be potential limitations of the school. Going for the next international Schroth scoliosis treatment, we have a very easy practical application from the patients, easy education for the therapists, and we have adequate overcorrection in specific types. And they use a lot of mobilizations, ADL training, and variety of exercises. Some of the limitations from this school could be sometimes a difficulty in classifying double curves and also the practical application of the technique for these curves. So many times it could be a little bit tricky whether to classify T-type or L-type when you have very balanced curves. And there is also a lack of one curve type in their clinical classification. So the THL type is not described. There is long exhalation, which sometimes could be difficult to maintain the expansion. And the overcorrection of the main curve sometimes could be risky for worsening the secondary curve. And there is a little bit less education compared at least to BSPTS for radiological measurements. Schroth Best Practice has a very easy practical application from the patients. They use less props during the exercises, and there is also a very nice application for mild curves. And maximum overcorrection is achieved in specific types. They work a lot with ADL training, also sagittal plane corrections, and there is some practical education with real patients. Some of the limitations could be the short total education, so it's 5 days for the main part and 3 days for the advanced. And there is a risk of worsening of the secondary curve by overcorrecting the main curve in every scoliosis type. Short theoretical education, no variety of exercises, just 4 or 5 in total for the basic part. And I think that in double balanced curves, like in Schroth ISST, could be a little bit tricky how to decide with exercises. The Lyon school has theoretical education of high quality. They use a lot of mobilizations, like in the lumbosacral area, sagittal plane correction, and activities of daily living training. Some of the limitations from this school could be the short total education, which is only 3 days, the absence of practical education, so no practice with exercises. And I think that it is a little bit less scoliosis specific compared to other schools, and there is no variety of exercises. Last, for SEAS, there is easy practical application from patients and therapists, very good technique for mild curves, dynamic exercises, clinical evaluation by making functional tests, and also good application for kyphosis. In some potential limitations, there could be a short total education, is 3 days for the advanced. difficulties for double curves, and by having the patient in initial education in sitting position, sometimes in severe scoliosis, this could be tricky, and there is no so much about mobilizations. So to finish this slide, I would like to repeat that by commenting on the strengths and limitations of the other schools, this does not mean that they are not good schools. What we try to do in our technique is that we try to minimize all the limitations and to keep all the strengths from these schools to create something new. So the strengths from our school could be a proper duration for education. So 9 days are enough to start applying the method in every type. And as you will see later, of course, you need also to follow level 2 to get the final certification in 15 days. So we tried to make this education to be not too much, but at the same time, not too less, because in order to say that you are really specialized in the scoliosis field, you need to get a proper education. Another strength is that in our school, we will give the option for basic course to be online, but with a teacher, not with some videos on the web. Should be an instructor, so that the participants can ask questions and have a better quality of education. There is a completely new clinical classification of curve type, and by this classification, it's important to understand when to overcorrect or when not to overcorrect. I think that from my experience, at least from working with all the other schools so far, one dilemma of the therapist could be when to overcorrect or how much to overcorrect. So I think that this new clinical classification, you can have the answer on that, and you can work much safer in our technique. So we aim to get the maximum of correction for types that is recommended for them. And of course, we need to avoid any compensation when this is risky. For example, in double and balanced curves, which, as explained in the previous slide, could be a limitation for some other Schroth approaches. We have a new technique for exhalation and muscle activation during the exercises. And as I said, based on this new classification, there is an advantage when you work with double and balanced curves. We have easy education for patients and therapists, which is, I think, really important, because you need to make it clear for all of them, both patients and therapists, during the courses. We have a high quality of theoretical education, a lot of information about scoliosis evaluation and kyphosis evaluation, clinical and radiological measurement, prognosis, and many other things that they are mostly included in the basic course. We have developed a unique patient form for clinical and radiological evaluation of patients with scoliosis and kyphosis, and this patient evaluation form will be delivered to our participants after level 1 course, so they can have it already prepared for them when they work with their own patients. We have some practical education with real patients, even from level 1. And we have the activities of daily living training from the very beginning of the treatment. We have a large variety of exercises for scoliosis and kyphosis. So most probably the largest variety from any other school. So in the first 9 days, the therapists, they have already learned so many exercises so that they can have a lot of options on how to treat their patients. However, at this point, I need to pinpoint that, of course, we offer many exercises in our education, but this does not mean that the most important thing is the quantity of exercises. It always should be the quality of exercises, so how the patient is able to go at a very good technical level to perform the exercises. But as I always say in my courses, the performance of the patient is not only dependent on the technical ability of the patient, but is also related to the skills of the therapist, how the therapist can bring the patient to go up at a high technical level to have the best performance during exercises. And to finish with this, our school can be properly adapted to any type of scoliosis or kyphosis. Here we have our educational plan. So we have the basic course, which is 3 days, could be done either in person or online live by Zoom with a teacher. And we have the theoretical education. We learn a lot of things about epidemiology, etiopathogenesis, prognosis, treatment indication for scoliosis and kyphosis. We have clinical and radiological evaluation of scoliosis and kyphosis. The classification that we use in our school, and an introduction in the 3D principle of correction for PSSE-Schroth method. Then we have the level 1 course, which is 6 days. So this is the practical part, and there is an education for all our exercises for scoliosis and kyphosis. There is a practice between therapist and a short practice with real patients. We have written exams, and the end of level 1 can give a certification for the participants to start applying the PSSE-Schroth method to their patients. And there is no time restriction to attend level 2. So one therapist that has finished level 1 can even come in the level 2 course in 3 months or 6 months or 1 year or 3 years or 5 years. There is no time restriction on that. And then we have the level 2 course, which is again 6 days. This level 2 course will be open for registration to therapists that they have already completed BSPTS level 1. But of course, when they enter level 2 course, they will need to have an explanation of the many differences between these two approaches, but they can have a good basis to start. So the therapists that they have already done level 1 as Barcelona Scoliosis Physical Therapy School, they can come to level 2, but there will be 2 different level 2 courses. So one level 2 course will be for those that they have already started as basic level 1 with our school, and there will be another option for those that they have been certified as BSPTS level 1 therapists, and they can come then to level 2 course, and then they can go to the next level. But of course, for them, they need more education to understand a lot of differences between our school and BSPTS. In level 2 course, we also have advanced exercises for kyphosis and scoliosis. We have everyday practice with real patients under the supervision of the instructor. We discuss about special scoliosis cases like congenital neuromuscular syndromic adult degenerative and postoperative. We have an introduction in the brace for scoliosis and kyphosis, and we have practical exams with real patients on the last day. And this course can give you a final certification in our school in PSSE-Schroth method. So in 9 days, you can start working with every type of patient, and the final certification comes in 15 days. There will also be an optional master's course for 4 days. This will be open also for registration for a BSPTS level 2 therapist, but for those people that they come from BSPTS level 2 or those that they joined level 2 after BSPTS 1, this course will be 6 days, not 4 days, because we will need a little bit more time to discuss with them about the differences and the new way of application of the technique. So in master's course, we also have everyday practice with real patients with supervision of the instructor. We have more information about other PSSE schools, advanced knowledge for brace biomechanics, surgical options for scoliosis and kyphosis, spinal fusion and other non-fusion techniques. research methodology and updated scientific data. And we also have some exercises for kyphosis and scoliosis that they are based on other techniques like Pilates, yoga, or TRX. Now, let's take a look on the scientific evidence behind scoliosis-specific exercises. As I explained before in this presentation, this term was introduced approximately 10 years ago. And from that point on, we had a lot of scientific evidence, many high-quality studies, randomized controlled trials that prove the effectiveness of scoliosis-specific exercises. So we have a growing evidence for that. And we also have recognition by the international scientific societies. And we have here a statement from the Scoliosis Research Society about physiotherapy scoliosis-specific exercises, and another position statement coming from the SRS, Pediatric Orthopedic Society of North America, American Academy of Orthopedic Surgeons, and American Academy of Pediatrics, and also the guidelines from the SOSOT. So the main messages from these statements are that scoliosis-specific exercises can be the first step in scoliosis treatment to stop progression and potentially to avoid bracing. And we have scientific evidence that scoliosis-specific exercises are superior to non-specific exercises, general or no exercises. And we have recent high-quality studies that have proven the efficacy of scoliosis-specific exercises in reducing the likelihood of progression. So, as I usually say, we are in very good timing nowadays that we have a growing scientific evidence. We have more and more recognition from the scientific societies, and this is good. But at the end of the day, we need to have our own good treatment results if we want to say that we really provide good treatment for our patients. Let's take a look now on the treatment indications. These are quite wide and recommended by the SOSOT guidelines in 2011. So what we do with scoliosis-specific exercises is to work with mild scoliosis, so usually below 25 degrees at research stage 0 to 3. Braced patients, independent of care magnitude. So for braced patients, we can work with a combination of brace and scoliosis-specific exercises. In larger scoliosis, but at a later growth stage, so 20 to 40 degrees when the patient growth stage is research 4 or 5, so close to the end of growth. And of course, we can work with any scoliosis patient in adult life, no matter the cob angle or if they are painful or not. These are classifications that are used by the techniques that are coming from the original Schroth method. So you can see the classification from Barcelona Scoliosis Physical Therapy School Rigo Concept is completely different to the Schroth International Scoliosis Treatment and Schroth Best Practice classification. So it is normal. I mean, this is what usually happens in many techniques, that there are some developments, some advancements by time. And all these schools, they try to treat the same condition, scoliosis, but they have their own way. So I'm not going to explain all this in depth, but I would like to comment a little bit on some of the limitations that came from these classifications. So for BSPTS-Rigo Concept, many times there is a difficulty for the therapist to differentiate between 3C and non-3, non-4, or 4C and non-3, non-4. And the problem is that the approach for these curve types is completely different when we work with a 3C or 4C or non-3, non-4. And also another limitation could be that BSPTS does not allow the maximum of correction in single curves, like norm 3, norm 4 without a lumbar curve, or group 1, 2, so single lumbar or thoracolumbar curves that are not allowed to get the maximum of correction due to the classification that is used for this school. International Schroth scoliosis treatment can have difficulties to classify balanced double curves, and also in terms of application, this could be a little bit tricky for the therapist, especially for the beginners, because overcorrection always occurs for the main curve. So sometimes it could be difficult to define between T-type and L-type. So T-type for this school is main thoracic, L-type is main lumbar, and the criteria that they use to classify are based on cob angle, flexibility, body weight distribution. So sometimes in very balanced curves, this could be very tricky. And as I said before, there is one clinical type that is missing, THL type. So when you have a patient with main thoracic scoliosis with hip imbalance, so the pelvis is shifted on the opposite side of the thoracic convexity, and at the same time you have a lumbar curve. So this is not described in their classification. Schroth Best Practice, there is again difficulty in balanced double curves because they always overcorrect the main curve. So sometimes, as I will explain later in our classification, this might not be very good, or it could be difficult for the therapist how to manage the patient, because it can result in worsening of this curve. So in our newly developed classification for PSSE-Schroth method, what we aimed was to get the maximum of correction when this is allowed or recommended, and to avoid compensation when we have balanced curves and this is not recommended. So we tried to, again, minimize the limitations coming from other schools. So our classification is mainly based on BSPTS-Rigo Concept, but with advanced ideas and also some influences from ISST and best practice. Our clinical classification, of course, is based on clinical criteria. So as I said before in the presentation, please always, before you look at the X-ray, you take a look on the patient. You need to have a proper clinical evaluation, and then you go to the X-ray to check if everything is in accordance with your clinical classification. So you need the radiological confirmation that it comes after your clinical evaluation. This, keep in mind, this should be the process that you have to follow all the time. Our classification is very easy and accurate in its application, and you just need to answer 3 questions to yourselves to classify all types. You will see the questions later on. The body is divided into blocks like in the original Schroth method, so it's the same for our school. And very important decision whether to overcorrect the main curve is taken from the initial classification with the signs plus or minus. And this decision for plus or minus is based on clinical, radiological, and prognostic criteria. But this classification can give you the chance to decide from the beginning how much you can overcorrect and to classify properly your patients to get the best treatment effect on them. And I also tend to think that in borderline cases, when you have difficulties how to classify them, our classification can make the choice easier for the therapist to classify and to choose the proper exercises. So when the therapist is in a dilemma to classify between 2 different types, here in this classification, they can find the answers. And to be honest with you, the way that this classification came on my mind was actually that in the last years, I faced this dilemma many times. So I tried to find a way how to minimize this difficulty for the therapist, and you will see later in our classification how we manage. So to classify in our school, you just need to answer three very easy questions. So the first question is, do we have a structural thoracic curve? The answer could be yes or no. Second question is, where is the pelvis according to the trunk? Only in the frontal plane. So this means that the pelvis could be either on the right, on the left, or in the middle, or in the thoracic convexity or the thoracic concavity, or balanced. And the third question is, can we overcorrect to give the sign plus or minus to your classification? Let's take a look on this classification. We have the K-type. K-type means thoracic kyphosis, KT, KTL, thoracolumbar kyphosis, and KL, lumbar kyphosis. So this is only sagittal plane deformity and kyphosis classification. Now, going back to the questions that you need to answer to yourselves, I said that we start with the first question, which is, do we have a structural thoracic curve? How can you identify that? Very simple way. You do the forward bending test and you check if you have a hump in the thoracic region. So if you have a structural thoracic scoliosis, then you definitely know that you are one of these three types. So 3C, 4C, or non-3, non-4 type. And when you have a structural thoracic scoliosis with the pelvis shifted to the thoracic concavity, this is 3C type. When you have a structural thoracic scoliosis with the pelvis shifted on the thoracic convexity, this is 4C type. When you have a structural thoracic scoliosis and the pelvis is balanced in the middle, this is non-3, non-4 type. And when you don't have a structural thoracic scoliosis, then you just have to wonder, do I have a structural lumbar or thoracolumbar scoliosis? So in this case, the classification is SL or STL, so single lumbar or single thoracolumbar scoliosis. Then the third question that you need to answer to yourselves is, can we overcorrect? So if you say, yes, we can overcorrect, this is 3C plus. If you say that, no, we cannot overcorrect, this is 3C minus. Same for 4C and non-3, non-4. I will need to explain something for the single lumbar and single thoracolumbar curves. We usually say that this is most typically plus, but I think that this classification to be more complete, we also need the SL or STL minus. And I will give you an explanation later on about this situation. So how can you decide to classify SL or STL minus? So the plus sign means overcorrection for the main curve in some or all exercises. So depending on the curve type, you can decide on overcorrection of the main curve in some hypercorrective exercises or in all exercises. When you decide for the minus sign, this means that no overcorrection is allowed for any curve in any exercise. And we also have introduced the term of S-type. S-type means structural proximal thoracic scoliosis, so when the apex is T5 and above. Let's now take a look on these images. So we'll take a look on all these 8 types that we have for scoliosis classification. This is the 3C plus, so structural thoracic scoliosis, definitely during the forward bending test, and the pelvis is shifted to the thoracic concavity. So this is 3C, and here is the X-ray of this patient. So you can see that there is a single thoracic scoliosis with a very, very minor lumbar curve with a very little rotation on the pedicles when you see on the X-ray. So this curve type, of course, can get some overcorrection during exercises for the main thoracic scoliosis. And this is why we call it 3C+. So for this curve type, we can get the maximum of correction with no problems. We have no worries of worsening the lumbar curve. And here you can see the 3C minus. So this patient is still 3C because we have a right thoracic scoliosis. So this is a thoracic hump, and we have the pelvis to be shifted on the thoracic concavity. However, do you believe that this kind of patient with this balanced scoliosis, right thoracic and left lumbar, and with this rotation in the lumbar scoliosis, do you really believe that this patient has the same characteristic with this one? No, I don't think so, because for this, the 3C+, you can get the maximum of correction in some exercises for the main thoracic curve without any risk of creating a compensation. But in this case, you cannot overcorrect. It's not a good idea, because if you overcorrect the thoracic curve, this will definitely have the tendency to worsen the lumbar curve. And for this patient, yes, it matters a lot. So this is tricky case, the 3C minus. Not very typical, of course. Most of the cases that you will see, they are 3C+. However, I need to explain for this case, also in relation with other Schroth schools classification. First of all, this is a type that is not described in Schroth ISST. This should be for them T, H, L type, but is not described at all. The problem for this type in BSPTS school will be that for Barcelona school, this patient would be classified as 3C, because this is only the classification, no plus and minus. This was a development from me and from our school, from PSSE-Schroth method. So in Barcelona school, they always say that 3C is always aiming to get an overcorrection for thoracic. But as I said, do you believe that this patient is the same with this one? No, I think that in this case, you must not overcorrect the main curve in any exercise, because you are in a significant risk of creating a worsening of the lumbar curve, which is already developed with a significant rotation. So not a good idea to overcorrect. This patient will also get an overcorrection as Schroth ISST or Schroth Best Practice, because it will be considered as T type for ISST. So the overcorrection will be done for the main thoracic curve. Same for Schroth Best Practice. This would be classified as 3C type, getting overcorrection for the thoracic. So in our school, we have a different approach that these patients can get correction, so can get to the midline, but not getting into overcorrection, because you will have a significant risk of worsening for the lumbar curve. Then I will explain first the 4C minus type, and then which is the most typical, of course. So 4C minus means that we have a structural thoracic scoliosis with the pelvis shifted to the thoracic convexity. And in this case, of course, you are not allowed to overcorrect. So this is a typical double major scoliosis when you have two balanced curves. And in this curve type, of course, you are not allowed to overcorrect in our school. For other schools, for Schroth ISST and Schroth Best Practice, this would be classified as L-type for ISST, 4C for Schroth Best Practice, and they will aim to get the overcorrection of the lumbar curve in any exercise, but this could be risky to create compensation or worsening of the thoracic curve, which is already big. So for us, this curve type will never get into overcorrection for any curve type. But take a look on this patient, which is not the most typical for C, but you can see this patient many times. So we have major thoracolumbar curve with a very minor thoracic scoliosis. There is some rotation. This is a complete curve on the X-ray because we have the upper end vertebra and the lower end vertebra to be both tilted to the horizontal plane. And this curve type looks to be completely different than this one. So for 4C minus, we can definitely not get into overcorrection, but for 4C plus, yes, we can get the maximum of correction for the main thoracolumbar curve, which is significantly more than the thoracic, but not in all exercises. For this curve type, we can decide to work in some hypercorrective exercises with overcorrection or to use the overcorrection techniques that we have in our school, but not in every exercises. So still this patient in most of the exercises will get into balance without overcorrecting the main thoracolumbar. But in some exercises, to get the maximum of correction, you can overcorrect the main thoracolumbar curve. So the general aim when you treat a patient with scoliosis-specific exercises is to get the maximum of correction, to get the maximum effect of that on the patient. So this is how this classification and this method came out, because this is the aim for us, to get the best, the maximum, the ideal correction that you can get for every patient. But when this is safe to be done, not when it is risky. So we tried to find a way to work with all these patients and to get the best treatment effect for them. So this curve type 4C plus will be overcorrected. If this patient was classified by ISST or best practice, this would be overcorrected, but not in Barcelona school. In Barcelona school, this would be 4C and no overcorrection. So as you can see, what we tried to do with this classification was exactly to find the best way to get the maximum treatment effect for the patient. And going next to non-3, non-4, here we have the definition of non-3, non-4 scoliosis. So it's a structural thoracic scoliosis with the pelvis to be balanced in the middle. And here, as you can see on this patient, we have a significant thoracic hump, and the lumbar spine is more or less straight with a very, very minor rotation. So can this patient get some overcorrection? Yes, in our school, this patient can get some overcorrection because we have a clear main thoracic curve, and we can get into some exercises. Again, not in all exercises, just in some exercises, the hypercorrective exercises from our school, you can get the maximum effect of correction for the main thoracic curve. And in many other, on the most exercises, you work to bring everything in balance. But the concept is, again, to get the maximum of correction. So in some exercises, you can decide to go to the overcorrection for the main thoracic curve, and in most exercises to stay balanced. So what you finally get by doing this is that you try to get the maximum effect in a safer way. You don't overcorrect in all exercises. You know what will be the problem with this curve type and with this patient in other Schroth schools. For Barcelona Scoliosis Physical Therapy School, the classification will be non-3, non-4, and no overcorrection is allowed for this curve type. So in some exercises, they lose the effect of the maximum correction for the main thoracic curve. For Schroth ISST and Schroth Best Practice, this would be considered as main thoracic curve. So in every exercise, they will work with overcorrection. But what could be the problem with that? The problem, if in every exercise you try to overcorrect the main thoracic curve, you have probably the possibility to develop a pelvic asymmetry. And this is definitely not what you want to get from this curve type, because the pelvis is already balanced and you need to keep it balanced at the end of treatment. So it's much safer to overcorrect in some exercises, but not in all exercises like what we do in our school. So for this curve type, BSPTS get less effect of maximum correction because it's not allowed. And best practice and ISST schools get more correction, but probably get a significant risk of bringing the patient finally out of balance when they overcorrect the main thoracic curve in cost of the pelvic imbalance in many exercises. Here, you see what we name as non-3, non-4 minus. So structural thoracic scoliosis with the pelvis balanced. This is non-3, non-4. But what do you think for this curve type? Is it the same like the previous? Do you believe that this curve type can be overcorrected in any way during any exercise, either for the lumbar or the thoracic? No, I think that this is definitely not a good idea. You cannot overcorrect this patient. So as you can see, this patient is non-3, non-4, and this patient is again non-3, non-4, but you have completely different characteristics of these patients. So you cannot say that I treat them in the same way. Of course not, because these are not the same curve types, and this is a main difference and advantage from our classification that we use for PSSE-Schroth school, because you try to find the best way to work with any curve type. And I think that this is a great development in scoliosis field, this way of classifying the patients. So for this curve type, non-3, non-4 minus, speaking about the other schools, for Barcelona school, it would be okay because they would not overcorrect. So I agree, definitely, there is no potential for overcorrection in this. But the other classifications, Schroth Best Practice and ISST, will overcorrect this patient for the main lumbar curve. But do you really think that for this curve type is a good idea to get overcorrection for the lumbar scoliosis? No, definitely not to my eyes. And this is why we would classify this patient as non-3, non-4, allowing no overcorrection in any exercise. But this is a different case. For this non-3, non-4 plus type, yes, we can get the maximum of correction in some hypercorrective exercises. So this is the perception behind our classification. Last types are the single thoracolumbar or single lumbar curves. And these are, by definition, single scoliosis. So we have no structural thoracic scoliosis, but structural lumbar or thoracolumbar scoliosis. We usually say that the most typical case is to classify STL or SL plus, but I have to tell you, because this is just a main curve, so this means that, of course, you can get the maximum of correction. Take care, in some exercises, not in all exercises. So even this curve type can get some overcorrection, but not in every exercise, just in some of them. And this is, again, I believe, a great advancement coming from our school, that you have the chance from the initial classification and from the definition of the curve types to define if you overcorrect, how much you overcorrect, and to do everything in a safer way to get the maximum of correction when this is allowed, and to avoid compensation of worsening of the secondary curve when this is not recommended. So This is the idea behind our classification. So I can tell you that for these types, so STL or SL, there is also another possibility to have STL or SL minus, but this is mainly related to adult degenerative scoliosis. So our classification also has this curve type STL or SL minus, which means that when you have an adult patient with a degenerative scoliosis, of course, for this case, you don't aim to get the maximum of correction, because for these cases, you have just to get stability of the curve. This is what you need, not to go to an overcorrection. So this could also be STL or SL minus, especially when you speak about degenerative adult scoliosis. I can also tell you from my experience that is not very frequent, but you can still have some STL types or SL types, so that you can have a single thoracolumbar scoliosis, for example, with the apex at T12, having a more or less straight thoracic spine and a structural proximal thoracic curve sometimes. This is something that it can happen sometimes. It's not really frequent, but it can happen as a special case. So this was our classification. I wanted to be a little bit more analytical so that I can give the idea to the audience of this webinar on the perception behind this classification and how this can give you a significant advantage compared to other schools on your decision for classifying the curve type and your approach with the exercises that you will choose for them to get the maximum of correction when this is allowed, and to avoid compensation when this is not recommended. Now, let's go to the 3D principles of correction that we use in our school. We have 4 principles of correction. The first is the 3D autocorrection. So here we have the self-elongation, the pelvic corrections, symmetrical or asymmetrical sagittal straightening, and corrections in the frontal plane. The second principle of correction is the corrective or rotational breathing. So during inhalation, we need to expand the collapsed areas in 3 dimensions. And during exhalation, we need to keep the expansion and the 3D correction. So not allowing the patient going back to the scoliotic position. And of course, we need to activate, we need muscle activation, which comes from the stabilization of the expansion during exhalation. And in every exhalation, we have more activation. So we have many different ways to increase the activation with or without external aids or props. We have shoulder traction, mainly for thoracic kyphosis, and for scoliosis, we have shoulder counter traction and thoracic counter traction, which is a very newly introduced term to describe the techniques that we have to expand the thoracic concavity in our school. And then, of course, we need stabilization and activities of daily living training. So to make it easier for you to understand the concept of our school, we first of all need to put everything in balance in 3 dimensions. This is 3D autocorrection. Then we need to expand the collapsed areas to get more correction. This is the corrective or rotational breathing for scoliosis. And of course, we need to activate in correction. This is muscle activation. And when we finish the exercise, we need a stabilization of the correction. And of course, we definitely need to implement the correction in the activities of daily living training. So during the exercise, we need to correct in 3 dimensions and going from a scoliotic posture to the corrective posture. And you can see in this patient that during exercises, everything is very well balanced. So we improve the shoulder asymmetry, the pelvic asymmetry, the trunk rotation, everything is very well balanced in every exercise. This is the correction during the exercises. But of course, then you need to educate the patient how to stabilize the correction in the daily life activities. So there are specific recommendations that we use in our school for every curve type. So again, this is curve pattern specific on how to sit, how to stand, how to sleep, which side, what to avoid during the day. And I think that this is very, very important and maybe the key point to maintain a good treatment result in the long term. So ADL training is an integral part of our school, and it should be for every scoliosis specific exercises school. Now I will very briefly try to explain to you what is overcorrection. How we define this. So overcorrection means to get the maximum of correction for the main curve. And to define if you overcorrect or not, you give the sign plus or minus as we saw before. So we have some curve types like the 3C plus or the SL or STL plus, which are curve types that allows you to get the maximum of correction for the main curve in most exercises. Still, even for them, there would be some exercises or other many exercises that you will get into correction. So, of course, in every curve type, we go into the ideal correction. The concept is that in some curve types, we are allowed to go into the maximum of correction, to get into some overcorrection and to do it safely, avoiding any compensations. So when we have 3C plus with a structural lumbar scoliosis, or non-3, non-4 plus, or 4C plus, this means that we can get overcorrection for the main curve in some exercises. So only in the so-called hypercorrective exercises, and we have a list of some of them here. So by saying overcorrection, we mean to use these techniques in the hypercorrective exercises, or to use in some exercises the overcorrective techniques, which could be pelvic corrections, frontal plane corrections, or sometimes lateral flexion for the main curve in some of these hypercorrective exercises. No overcorrection in any exercise is allowed for the minus types. So 3C minus, when you have a 3C with a significant structural lumbar curve, you are not allowed to do overcorrection. Non-3, non-4, again, with significant lumbar scoliosis. So when you have very balanced curves, thoracic and lumbar, this is not a good idea to get into overcorrection for any curve. 4C minus, the most typical when you have 4C with a significant structural thoracic scoliosis. And the curve type that I explained before, SL or STL minus, when we speak mainly about degenerative scoliosis. So this is a brief explanation to understand better about the overcorrection and the decision of plus or minus signs. Here is the terminology that we use in our school. Again, we have innovative terms that were introduced for the first time, some of them from our school. So we have the number one, which is the thoracic convexity. Here we have a patient with a 3C plus and a patient with 4C minus, so you can see on them. So thoracic hump is the thoracic convexity, the number one. Lumbar hump is, or lumbar convexity is the number two. And we have weak side and weak point for the thoracic concavity and the thoracic and the lumbar concavity accordingly. So when we divide the patient's body into the middle, so into left and right side, we have the thoracic side to be the side of the thoracic hump or the thoracic prominence, and the lumbar side to be the side of the lumbar hump. So it is very easy to remember for the therapist that the side of the thoracic hump is called T side, thoracic side. The side of the lumbar hump is called L side, lumbar side. So this is easy to understand. And of course, then we have the L side shoulder, L side elbow, L side pelvis, or T side pelvis, T side hand, T side knee. Number 8 is called shoulder concavity because it is in the shoulder block, so in the upper block above the thoracic, and this is a concave part of the shoulder block. And when you look from the front view, of course, what we know is that due to the rotation of the thoracic block, or when we have from one side the thoracic hump, on the opposite side we have the ventral rib hump protruding to the front, and the area in front of the thoracic hump is called a ventral flat zone on the T side, and this is also a newly developed term by us, because we can have a possibility to have a ventral flat zone on the L side, and this is mainly related to thoracolumbar curves, mostly when the apex is T12. It also can happen when the apex of the thoracolumbar curve is L1, and you have the curve to go too much high in the lower thoracic region. So this means that you have ventral flat zone on the L side in front of the thoracolumbar hump, and at the same time you can have ventral thoracolumbar rib hump on the other side. So these are new terms that were introduced from our school. Now, let's speak a little bit about the corrective or rotational breathing. So we have a deep inhalation from the nose, aiming to expand the collapsed areas to the corrective direction. And during exhalation, we have a duration of 4 to 5 seconds, and we need to preserve the expansion and to avoid returning back to the initial position. And of course, we need axial expansion, which is cranial and caudal. So we need to keep the self-elongation. This is the purpose of the axial expansion. And we have the expansion on the weak side, so the thoracic concavity, weak point, the lumbar concavity, and the ventral flat zone to be always, for the weak side and the weak point, lateral dorsal cranial, and for the ventral flat zone to be ventral and cranial. We also have the L side shoulder, which is the area in front of the shoulder of the lumbar side. When you have an S-type, so when you have a proximal thoracic scoliosis, this means that you have a true shoulder hump at that time on the L side, and you have actually a ventral flat zone in front of the shoulder hump. So you need to expand this area ventrally to correct the shoulder hump. Is the same concept like with the ventral flat zone on the T side, which is in front of the thoracic hump. So in the muscle activation, we have the first way to activate is by stabilizing the expansion and the 3D correction during exhalation. And of course, in every exhalation, we have more activation with the use of props or without the use of any props. And we have the tension techniques, the shoulder countertraction, which is very widely used, and it comes from the original Schroth method and the newly introduced term thoracic countertraction, which comes from our school. So this is a development coming from PSSE Schroth method. And of course, we can have pressure with many props like the poles or the band or the wall bar or other props. So the shoulder countertraction on the thoracic side is used for the correction and expansion of the shoulder concavity. It protects worsening of the shoulder block to the L side and is a very, very important technique in S-type. So when you have a proximal thoracic scoliosis, these special technique, shoulder countertraction, plays an important role to open the shoulder concavity, which is structurally collapsed in S-types. The thoracic countertraction, which is a new term, is a technique that is used in every curve type in our school to correct and expand the weak side, so the thoracic concavity, by stabilizing the lumbar, or sometimes, depending on the curve type, also the pelvic block. So we have a pair of forces working for these situations. So here you can see a pair of forces for the shoulder countertraction on T side for 4C plus and 3C minus types. And you can see also the forces, how they are applied on the patient's body and on the X-ray of the patients. And you can see the thoracic countertraction and how this technique is applied in a 3C plus or in a 4C minus type thoracic countertraction on the L side. And as we usually say, when the exercise is finished, then the actual treatment really starts. It is the ability of the patient to keep the correction during the daily life activities and to get a stabilization of the correction. So here we have a patient which is actually after a spinal fusion, ventral spinal fusion. And you can understand the importance of this patient, that even you can see after spinal fusion, the scoliosis is still there. This means that the asymmetrical loading of the spine and the discs and the trunk is still there. And we need to unload the spine during the daily life activities. And you can see this significant curve after spinal fusion. How can it be improved? By giving them the proper recommendations for daily life activities. So how to stand, how to sit, how to sleep, on which side. And you can see the immediate effect of unloading of the collapsed area on the weak point for this patient by just getting the good positions that we want them. And I need to clarify something for the activities of daily living training. The concept is to get some correction for the main curve, and at the same, of course, you don't expect that you can get the perfect 3D correction that we give to the patient during the exercises. This is impossible, because at the same time, for the ADL training, you need also to have your patient able to hold this position for a long time, because this is the purpose for the ADL training. You need corrective positions for the main curve and to be comfortable in some way, so that the patient is able to hold this position for a good duration during the day, because this is exactly the concept, to unload the spine in daily life activities. The last part of this presentation will be to present you some of the treatment results that we had during all these years in our clinic by using the PSSE-Schroth method. So, as I said before, it's okay to say that we have good scientific evidence for PSSE schools, and this is true. This is reality nowadays. We have a growing evidence. We also have the recognition from the scientific societies, and this is very good. But at the end of the day, you need to provide your own good treatment results. And here you can have a short presentation of some of them coming from our clinic. So here you can see a patient of 20 degrees of scoliosis, so very close to the brace indication range, with left thoracolumbar scoliosis and a pelvic asymmetry and a left rotation. You can see the patient before treatment, and just 1 year after treatment, we achieved to reduce the scoliosis to 7 degrees. So the main aim was to stop progression, but as you can see, in some cases with a good treatment, you can even get a significant reduction of the cobang, and also a very significant improvement on the patient balance. And also you can see the improvement in the trunk rotation for this patient. Another treatment result for a patient exactly at the borderline to be braced with 25 degrees of scoliosis and very significant pelvic asymmetry and trunk rotation. And in this patient, almost 1 year later, we achieved to reduce from 25 to 10 degrees, doing only exercises, no brace. And if you take a look on this X-ray to compare the vertebra rotation during the X-ray by the position of the pedicles and the position of the spinous processes, you can see a very significant correction of the vertebra rotation. This can, of course, can give us the exact confirmation that what we do is a 3D correction, is a detorsion of the spine, combining techniques in all 3 dimensions. This is what we offer in our school. Another patient, adolescent, but at the end of growth, with a curve of 31 degrees thoracic and 34 degrees lumbar scoliosis, with a pelvic imbalance and shoulder imbalance and trunk rotation. And you can see the result that we got into this patient almost 3 years after starting our treatment in the clinic. We reduced the curve from 31 to 22, from 34 to 20 degrees, getting a very nice clinical improvement for this patient. As you can see, our treatment method can be very beneficial for any curve type, also for double curves like this. Here we have another patient, again, the research 4 with 30 degrees of scoliosis. And we reduced the scoliosis from 30 to 13 degrees 2 years later, getting a very nice clinical improvement. And again, you can see the significant correction of the vertebra rotation on the X-ray when you can see the pedicles here and you can see the pedicles in this position, in this X-ray. So this was a very nice treatment result. Again, only with exercises, no brace treatment for these patients. I would also like to show you some of the results that we can have in adult scoliosis doing only exercises. Here is an extraordinary good treatment result for a lady almost 40 years old that came to our clinic with a 73 degrees of right thoracic scoliosis, and you can see the pelvic imbalance and the thoracic hump. We achieved to go down to 55 degrees, so 18 degrees less in this very severe scoliosis, doing only exercises, and you can see the clinical improvement of this patient. Of course, I have to admit that this is not something that we see every day. We wish that we had in every patient with a very severe scoliosis to have almost 20 degrees of reduction. Of course, this is not possible, but for this case, that the patient was really compliant with the program of exercises and quite flexible enough despite the large curve magnitude. We achieved a very significant reduction of the scoliosis and a clinical improvement at the same time. Another case with 41 degrees of scoliosis, young adult at the age of 23, 24 years old, with a very significant thoracic hump. You can see the difference of the pelvic balance and the thoracic hump, and also the frontal plane balance and reduction of the cob angle. Another case, young adult. I can tell you that these category of patients, so young adult patients, are, let's say, very good candidates to work with scoliosis-specific exercises and to get some nice correction for their curves, because they are adults. So this means that they are not still in growth. So there is no high risk for rapid progression. This is one good thing. And they are still young adults. This means that they don't have degenerative changes in their spines. So these patients can have a great potential of significant correction of their scoliosis. And what you can see here is from 53 degrees, we went down to 46 degrees, and also a very nice improvement in the clinical balance of the patient. And again, take a look on the vertebra rotation on the X-ray. You can see the pedicles here before treatment, and you can see the pedicles after treatment. So we got a very nice correction in the vertebra rotation as well. And lastly, I would like to share with you some of the results that we have in our clinic with a combination of brace and scoliosis-specific exercises Schroth method with PSSE-Schroth technique. So in our clinic, what we do is that when a patient, what I personally do is when a patient has brace indication, I refer the patient to my orthotist, and I give all the proper recommendations for the brace design. So this is something that I typically do for every patient in my clinic. This is one thing, so the initial brace design, and of course, later on during the treatment process, you need to make the proper adjustments to the brace because the patient is growing up and the brace should be modified in some way. And this is also something that is done personally by me for every patient in my clinic. So here you can see a patient with a double scoliosis 32 and 33 degrees, so double curve. And this is the result that we got without the brace in a little bit less than 2 years. So we got a very significant reduction from 33 to 8 degrees for the lumbar and from 32 to 16 degrees for a thoracic. So again, an extraordinary good treat result, and you can see the clinical improvement on the patient body. Here is a case of 31 degrees of scoliosis left thoracolumbar with 17 degrees of right thoracic. We brace these patients and you can see the very nice correction in the brace. So the curve went down from 31 to 2. So we know that for in brace correction, we, let's say, normally aim to get a minimum of 30% of correction. And here you can see that we almost got 100% of correction, and the final treatment result was with a curve of 10 and 12 degrees. Of course, this is a very young patient, and we still need to follow up this patient, but we have removed the brace since last year, and the patient is still stable, doing only exercises. So this is a case when we started treatment below 10 years old, because this patient was at the age of 6 when we started our treatment, and now is at the age of 8, being already 1 year out of brace, stabilizing the correction only with exercises. So this is a great benefit for this patient to be already 1 year out of brace, and maybe, who knows, in the future, maybe we don't need the brace again. So this is very important treatment result. Again, a patient with 27 degrees of scoliosis, right thoracic, and what we got in the in-brace X-ray was to go down to minus 24. This means that from a right thoracic scoliosis 27 degrees out of the brace, we got to 24 degrees left thoracic. So we got overcorrection in the brace. This is something really good that you many times want to get in single curves. However, you need to take care on how to manage this situation, because if you don't take care and if you are not familiar with the brace design and brace correction, maybe you can go to creating a compensation. But in this curve, as you can see, we didn't create any kind of compensation. We had an excellent correction, bringing her scoliosis from 27 down to 10 degrees after 2 years of treatment. And of course, we can also get very nice correction for curves even more severe, so more than 40 degrees. And this research was actually published some weeks ago from our clinic for curves more than 40 degrees treated at the peak of growth with a combination of brace and PSSE-Schroth method from our clinic. So you can see these 48 degrees of scoliosis going down to 39, and you can see a very nice correction in the clinical balance of the patient and the trunk rotation. This was the in-brace X-ray. So even in this very severe scoliosis, we got a 50% of correction in the brace, and this was a very good prognostic factor, together with the compliance of the patient, to get this excellent treatment result at the end. This is another patient with 45 degrees of scoliosis, and we reduced the scoliosis to 34 degrees. And again, you can see a very nice improvement in the clinical balance of the patient. So I think that this is also very, very important to understand. What we treat is not the X-ray. What we treat is the patient. And we need, at the end of the day, to have a satisfied patient, not only for their X-ray, because the X-ray is not something that can be seen by the others or by the patient. The external appearance, the clinical body image is maybe even more important, the correction compared to the X-ray. So as you can see for this patient, we have now a perfect balance with almost very, very minor thoracic hump compared to the initial situation 2 years ago. And another treatment result, again, coming from my clinic with a combination of brace and scoliosis-specific exercises, Schroth method, our technique. This curve started from 65 degrees at Research 1. So at that stage, no orthopedic surgeon gave any chance for non-operative treatment to the family. But when they came to our clinic, I told them, of course, we can start working with an intensive treatment with brace and exercises, and I'm sure that we can get a good result. And this was the result just 1 year later. We reduced this scoliosis almost 20 degrees, getting this very nice clinical correction for the patient. So as you can see, even with more severe scoliosis, we can still get a very nice treatment effect when we have proper treatment with brace and the PSSE-Schroth method like in our clinic. And at that time, I would like to thank you for attending this webinar. And if you want to find more information about our courses, you can send us an email on this email account, or you can visit our website, or you can follow us on the social media. So very, very soon, we will announce the dates for international courses that they will take place in Greece. There are already many seats that they are pre-booked. We will give the option for the basic course to be online. So from all over the world, you can be educated in scoliosis treatment, at least for the basic part, without the need to travel. So the technology now allows us to do that and to keep very high quality of education. And also level 1, level 2 courses and master courses will be announced very soon. So please stay tuned with us, stay connected with us. You can follow us in the social media or write us in our webpage or email. And I really thank you for attending this presentation, and goodbye to everyone.